And now let's start with topic 1. This is which is the very basic and fundamental of hernia surgery is the anatomy of the abdominal wall and the retrorectus space. And I would welcome, and she is an instructor of the MS program, and she has a very many experience with ventral hernia surgery. And please welcome Dr. Piyanun Wangkulangkul.
Good morning, everybody. Did you sleep well? Enjoy Hat Yai food. Yeah, I'm Dr. Piyanun Wangkulangkul. I'm the instructor here, and I'm really glad to see you here today. And welcome to Songklanagarind. Today we got to have a live demonstration TAPP ventral hernia repair and seal TAPP. Okay, and this mini lecture, I hope it may help you to better understand abdominal wall anatomy. It's related to the abdominal wall reconstruction. Okay, about the TAPP like this, you in the cave, and I think more surgeons would be interested in the ridge stopper and the TAR, and but the retromuscular dissection might make us get lost if we don't know anatomy. And this space could be needed more understanding because it may relate to the injury or the failure or successful. The anatomy is very important. The outcome depends on how well you know the anatomy. Okay, I would show you the 3D animations. It's better to understand anatomy. Okay, take a look at overview of the abdominal wall. Most surgeons are familiar with the abdominal wall muscle groups, external oblique muscles, and internal oblique and transversus abdominis, right? And here the internal oblique muscle, and the middle group is the rectus abdominis muscle. It's connecting with the linea semilunaris, and the rectus muscles connect together with the linea alba. The linea alba is the white line. This is composed of the fibrous muscle and elastin, collagen. The length of the linea alba about 1.5 to 2.2 centimeters. Anything more than this is called the aesthetic linea alba. And then look deeper. It's here. The transversus abdominis muscles, and the lower is the aponeurosis. And here the green line is the linea semilunaris. Take a look on the red dot. The transversus abdominis muscle take really long in upper, and the lower below the arcuate line is have only the fibers. Okay. The transversus abdominis, you know, is like a causes of abdominal wall because it's like a causes across to the back and attach the back muscles to behind. And when we close up and cross-section above the arcuate line, let's take a look on the cross-section. When you cross-section at above the arcuate line, and here you can see the lateral muscle group, the external oblique muscles take a fibers to the anterior rectus sheath, and the internal oblique muscle splits to two lamellars, anterior and posterior lamellars. The anterior lamellars join together with the external oblique aponeurosis to be an anterior rectus sheath, and the lower, the posterior lamella, join with the transverse abdominal aponeurosis to make a posterior teeth. So, and here we have a different, and I will show you the below arcuate line again. Okay, when we turn back and see inside of the abdomen, you can see here the posterior teeth end at here, the arcuate line. Okay. And below the arcuate line, the cross section look like this. Below the arcuate line, there have no the posterior teeth. It start only rectus muscles, the transversalis fascia, and then the peritoneum. You can see here the transverse abdominal aponeurosis take off to the anterior teeth. Okay, look again and here, like it's take to the anterior. Okay, let's look more the linea semilunaris. And here, the linea semilunaris location is maybe different location, but it's attached the lateral of the rectus abdominal muscles. So the rectus abdominal muscle is very important for the retrorectus space, the section and repair, because of if it maybe varies, because normally the rectus abdominis maybe 7.5 centimeters, but it can be very narrow, like 2 or 4 centimeters, that make the space not enough for misplacement. So at that time, the tires will be required. Okay, so we gonna talk more about the transversus abdominal. For the abdomen, we split to the upper umbilicus level and the lower abdomen below the arcuate line. You can see here, the diagram show the different color. The green is the external oblique muscle, and then internal oblique and transversus abdominis. The number 1, you can see here, the muscle is long. So when you do the tire, it's not the strength. It's curved to the medium. And the umbilicus level, like the muscle, maybe some short of the group that elongate about just above the umbilical level a little bit. And below the arcuate line, the transversus abdominis is very laterally. It's had only a aponeurosis. And I got to talk about nerve, because the very adverse effect of the tire is the nerve injury. So but it's only the sensory nerve. The patient will got the numbness or neuropexia when you do the tire and injury this nerve. And you can see here we split to 2 parts. The upper, the nerve get between internal oblique and the transversus abdominis and take it up to the rectus muscle. But the below arcuate line, the ilioinguinal and iliogastric, and here the hour levels, that landmark is the SAS, and here the nerve to take early to the anterior sheath. Okay, more animation. For the nerve distribution, finally, you can see like here, the nerve, the end of nerve at the rectus muscles. And you peel the internal oblique off, you can see here, the nerve run upper the transversus abdominis. Here. So the ilioinguinal and iliogastric at here is take above before it's take above early. And when you see inside of the causal nerve, subcausal nerve from the rib, take from posterior to the anterior. So the lateral, you cannot dissection beyond this because they got the nerve injury. And here you can see here the external oblique and and here the nerve run between the internal oblique muscles and the transversus abdominal muscle. Okay. So like Dr. Sikung said, the retrorectus dissection can make a space, and you can do the TAR for the lateral dissection, and you can connect it in a one piece like if you connect the falciform ligament and the umbilical ligament plane down, it's a very big space for hernia repair. Okay, I want to show you about the retrorectus space dissection. And here you can take this space very easy because it loose tissue and alveolar tissue. And here you can use a balloon space maker or use the blunt part or total technique. The neurovascular bundle is the landmark of the lateral. And you can see the arcuate line over there. And if you want to get the more space, you do the TAR. The TAR, like I said, the line for the section is like a curve. Because of the muscle distribution, it changed in the upper. It's on the cadaver dissection. You can see you can very loose. The under the transversus abdominis is the transversalis fascia. It's thin, but it's very tough. Okay. And under the transversalis fascia is the peritoneum. Don't be aware of the cut in this plane. The robotic, I would show you about the cup subcostal because some surgeons are familiar with this plane. Okay, you can see the landmarks, neurovascular bundles, rectus muscles, and the posterior sheath. And okay, we get start the TAR medialized to the neurovascular bundles. Split the muscle, and you can see here the transversalis fascia is down, is below to the transversus abdominal muscle, and the lateral side the same level. I want to show you diaphragm connect to the transversus abdominal muscle in the upper. So for the arcuate levels, many surgeons familiar with this area because we do the groin hernia repair, right? And here the same principle, do the release the posterior oblique lamella of the internal oblique muscle, and the transversus abdominis run the upper. Okay, I would conclusion. And I think the restopper and the TAR space is very big space for in every hernia. Abdominal hernia repair, you can make this procedure for do the magic space for hernia repair. Okay, was short, brief. Thank you for your attention. Please feel free to ask questions.
If you have any question right now, you feel free to ask Dr. Piyanun about the anatomy of the abdominal wall and retrorectus space. Any question? I think this is a wonderful short brief. Okay.
Thank you for the wonderful talk. Can I ask, when you do your transversus abdominal release, the TAR, how do you avoid the nerves? Which level do you cut the fascia to avoid the nerve injury?
Because the nerve location is run along the transversus abdominis, like the lower is the lateral and the upper is close to more medial. And you can see the color of the nerve is the neurovascular bundle complex. So it's not heavily vascular. you see the nerve. Some patient easy to notice. It's like a white and red, okay, vessel and nerve. But if you have only vessel, it's not neurovascular bundle. And it's like a lamppost sign. It take a long road along the abdominal wall, the lateral abdominal wall. And the upper, please notice if you go to the upper or subcostal area, is the move to the more medial.
Thank you. Is there any question?
Dr. Warabutt, do you like to add something?
Or you have anything to share with us?
Nothing to share, but congratulations for a great talk. Maybe I'll add on a little bit. Basically, the level when you cut the transversus abdominis is different. I mean, above the umbilicus level, it's pretty obvious that you can see the TA muscle very clear. So I would recommend you to start doing TAR at from head to toe first. I mean, craniocaudal fashion. So you see the muscle layer nicely, and then you just cut it. Okay. When you dissect medial to lateral, you will see the neurovascular bundle coming up from down to upper part, right? You just stop it. No need to go further other than that. Otherwise, you can cut like the nerve and also the other muscle part. So I would recommend you go medial to lateral and you stop when you see the neurovascular bundle, okay? And then you just cut the muscle about 1 or 2 centimeters just before the nerve, okay? And then you just start from head to toe, cut it. And then when you are close to accurate level, that's become like a pulmoneurotic part. It's not a muscle part. So that's part gonna be very, you have to go slow. Otherwise you get into the abdomen. So that's why I recommend you start from the top first and then go slowly to the below. Stop when you see the nerve. That's it. And once you separate the muscle, right, and the pulmoneurotic part, right, you can go underneath, okay, underneath the muscle, go far as possible. You can go to the spine. So that's the point, how to not get injury to any nerves. Okay.
Thank you, Dr. Warabutt.
Listen, to me, I think both bottom up and top down, the section is fine if you're familiar with the anatomy. But the hardest part is the change of the transversus abdominis that just close to above the SIS, that's close to the umbilicus level. This space is very thin because the transversus abdominis just a little bit change. This anatomy may make you confused. And here, take the upper or lower. That start, it depends on your hernia. Lower is to be fine, but avoid to start at the umbilicus level.
Yeah.
So thank you a lot, Dr. Warabutt, for your advice, and also Dr. Piyanun for a clear and insightful talk about the anatomy of ventral hernia and retrorectus space. We learned a lot.